form of the impact and the direction of the laser in the peripheral part of the ablation is confounded by a obliquity, the lack of influence, and so we have to make some adjustment for that. In addition, we have to adjust for biomechanical changes because there's some retraction of the cut fibers, and of course, there's wound healing. So all of these factors have to be brought together in order to give ourselves the kind of contour that we want. And the problem that we've got on these ablations is that if we do a preoperative cornea that has a normal prolate shape, do a myopic LASIK, then we get this kind of an oblate pattern with this red ring. And the talk that we just heard from Chancellor's group wants to get rid of this red ring. That's what we want to get rid of, and get rid of the induced spherical aberrations. So to deal with these problems, the Nidek group, with Jack Holliday doing the designing of this particular software, Dr. Eldana Suri doing the clinical trial that I'm going to describe to you, and I'm the monitor of this group. We're all paid consultants for Nidek, are going to introduce something that you've never heard of before. And you'll be very glad you got up so early this morning, because we're going to tell you about OPA, optimized prolate ablation, and we're going to compare that to the Nidek conventional treatment. The goal that we have is not just wavefront guided, not just topography guided, but to take the baseline corneal shape, read the topography with these variables, take the preoperative wavefront of the whole eye, not just corneal wavefront, and design from that, this is the patient's beginning cornea, the corneal shape that we want to have at the end. So if you take the original shape minus the corneal shape, that's the ablation profile that we have to make. In other words, we're doing a per cornea design with this. And this slide's a little bit busy, but you can see that we did do iris registration, online torsion, live torsion correction. We're not treating on the pupil center. We're not treating on the apex of the cornea, first Burkinia image. We're treating actually between the two, near the visual axis, which you really can't find. Nice blend zone, and two different types then of software. The aberrometry plus the topography for optimized prolate ablation, and for conventional we use the final fit software. Eyes use one eye OPA, one eye standard, and these were randomized in a prospective fashion, so it's a very nice study design. Treating average between the two groups was quite similar. There was no difference at baseline in the distance-corrected visual acuity. Everybody saw 20/16 or 20. Frames are great because they let you see where every eye falls. And you can see in the two groups, OPA and conventional, that we have a very tight cluster around the line of getting the same thing we wanted, or the same refractive outcome, essentially. But now we have in the OPA group, half the patients, uncorrected, seeing 20/16, and in the standard group, only 25% seeing 20/16. So in visual terms, OPA is twice as good as the standard. If we look at the corrected vision, OPA is a little bit better, but they both come down just fine. No difference in contrast sensitivity. I'm going to skip this. Here's the crux. With the standard, we induced a lot of spherical aberration. These bars go up. At baseline, this light is out. Maybe this one is good. At baseline, we had negative spherical aberration, the same in both groups. The negative spherical aberration stayed the same in OPA. And look at this. The same value before and after. Whereas with the standard, we increased these. So instead of getting the red ring, as we did with the standard conventional, instead of getting an oblate cornea, we got a prolate cornea with no red ring. Now you might say, well, prove it, George. Okay. I want you to look in these slides just at this picture. This is the topography, And this computer interpretation from the Kleist Navigator saying it's normal. And they want me to quit, but I want to click through these. Just watch each of these. You cannot tell the post-operative cornea in the upper left-hand corner, which is read as normal, from the pre-operative cornea. Have you ever seen that with a myopic ablation, where you can't tell the topography post-op from pre-op? The answer is no, you've never seen that before. So that's why you were glad to get up early this morning. So we have a similar refractive outcome, better visual outcome with OPA, and a prolate cornea afterwards with less induction of higher order aberrations with this custom designed topography plus wavefront software that Nidek calls OPA. Thank you.
Thank you very much, Stuart.